Welcome, everyone. Good afternoon. This is the first clinical meeting of the Association of Otolaryngologists of India, West Bengal chapter for the session 2022 and 23. I would request Dr. Haradhan Bora, the present president of the Association of Otolaryngologists of India, West Bengal, to please come up, sir, and give your welcome address.
Very good afternoon to all you. This is the first clinical meeting of the year from Association of Otolaryngologists of India West Bengal branch. I am welcoming you, all the members of the association, the participant of the clinical meeting to be held on today, and also welcoming Dr. Shurmishta Bandyopadhyay for arranging such a good academic meet at the auditorium of Bhagirathi Neutia Hospital, Women and Child Care. I think you will all enjoy the beautiful academic fest of the day, and we will all enjoy and enrich our knowledge so far. I first invite Dr. Anuruddha Majumdar for deliver his lecture on vertiginous migraine. Dr. Majumdar, please.
Good afternoon, all. It's an honor, pleasure, and privilege to be here. At the outset, I'd like to thank President AOI West Bengal, Secretary, and all the Executive Committee member for giving me the opportunity to talk in this topic. My topic is vertiginous migraine or migraine-related vertigo. The slides all given by the Johnson & Johnson, and I will try to give my honest opinion on that. So vestibular migraine is very important. As a ENT surgeon, in our day-to-day practice, we deal all vertigo patients, especially peripheral vertigo. Next to BPPV, it is the most important. Next to BPPV is the second most common cause of vertigo. So it's very important from as a ENT surgeon point of view. So what is vestibular migraine? It's an episodic vertigo associated with migraine. We are well oriented with migraine. So it's also related with migraine related vestibulopathy. So etiology, just like migraine, etiology is not completely understood. But if we come to the pathophysiology, it's a complex interaction between vestibular nuclei, trigeminal system, thalamocortical processing center. So many systems are involved. Mainly that is the spreading and cortical depression that leads to vasoconstriction and vasodilation of intracranial and extracranial blood vessel. So is it the association between vertigo and migraine is a chance or coincidence? So if we go to the pathophysiology of a migraine and vestibular migraine is same. So data shows it's definitely a definite correlation with migraine and migraine related vertigo. So there are different criteria set by the International Headache Society and Barony Society for diagnosing migraine-related vertigo. So there are very simple Barony Society criteria for vestibular migraine, that recurrent vertigo of moderate to severe intensity, usually lasting 5 to 72 hours. And 5 episodes of vertigo in past 2 years, and concurrent or previous history of migraine, and one or more of the following migraine symptoms like migraine headache, photophobia, phonophobia, aura. So this will associated with vertigo. So headache may or may not present in vestibular migraine. And another terminology is probable vestibular migraine. They set the criteria, that is the recurrent vertigo, moderate to severe intensity, and one of the following like current or previous history of migraine symptoms during at least 50% of the vertigo attack, and menstrual precipitation at least 50% of the vertigo. So these are some criteria we can use in our clinical practice. And what important and main diagnosis is from history. So history is very important, and what are the points in history is very important, like is there any history of colic from early infancy, paroxysmal torticollis in infancy, benign paroxysmal positional paroxysmal vertigo of children, typical migraine headache, and recurrent episodic vertigo, and family history of migraine. So these are the points we need to inquire during history taking. So or if either of these symptoms are present, and we can correlate with migraine as vertigo. So symptoms are sometimes vague, but yes, vestibular symptoms is the main, that is spontaneous vertigo, that is sometimes rotational or sometimes positional, head motion induced dizziness, and cochlear symptoms like oral pressure, autonomic like nausea, vomiting. So these are some points we should keep in mind. And visual external vertigo, and of course and migrainous symptoms like photophobia, headache, phonophobia, visual aura will be there. So what are the role of investigation? Mainly to diagnose vestibular migraine, clinical diagnosis is the main. So there is no sophisticated investigation per se not required to diagnose vestibular migraine. So yes, VEMP we can do, though it's non-specific. Video nystagmography also we can do for documentation. But definitely it's a clinical diagnosis. History is very important. And as a clinician, we need to do radiological test to rule out any CNS pathology. And of course, vestibular migraine neurological opinion is very, very important. And in physical examination, apart from general physical examination, we do all the vestibular test. We are doing in our day-to-day practice, we are doing all vestibular test, like examination of the eyes is very important. Look for nystagmus, and other tests, as we all know, hints, head impulse test, and visual impulse test. So all the tests are common, so nothing specific. We should do all the routine test. And most importantly, examination of the eyes, look for nystagmus. And difference between aura epilepsy and aura of migraine, that's why we should always take an neurological opinion. So from clinical point of view, that aura is in epileptic aura it's less than 5 minutes, but in migraine related vertigo or migrainous vertigo, aura is bit lasting longer, usually several minutes to hours. So coming to the treatment, yes, it's a multi-pronged approach. So apart from pharmacological treatment, very important is lifestyle modification and trigger avoidance. So we need to understand the triggers. What are the triggers for vertigo? So we need to ask from history. And physical exercise and vestibular adaptation exercise plays a very, very important role. Coming to the for trigger avoidance, just like migraine headache, we always advise patient to avoid chocolate, cheese, red wines, and some Chinese preparation that containing monosodium glutamate as a preservative. So we should tell the patient to avoid all this. And high salt diet, stress, definitely sleep deprivation is a aggravating factor, and lifestyle modification is very, very important. In pharmacological management of vestibular migraine, anti-vertigo drugs, we always it's a first line of drug, triptans, yes, serotonin inhibitors, ergotamine, and acetazolamide. So these are the drugs for prophylactic treatment, like beta blocker and calcium channel blocker is the main first line of drug, and so serotonin uptake inhibitors are the second line. So main treatment is calcium channel blocker like cinnarizine and dimenhydrinate 40 milligram. It's twice a day for at least 2 to 3 weeks. So fixed dose combination cinnarizine and dimenhydrinate is the prophylactic therapy for vestibular migraine. So as we know, the vestibular migraine is one of the frequent cause of episodic vertigo. So its prevalence is around 1%. Prophylactic therapy, so treatment mainly in acute phase and prophylactic phase. In acute phase, always we prefer non-steroidal anti-inflammatory drugs and some triptan groups, and if it fits into the Barani criteria, we should initiate the prophylactic therapy if we diagnose it. So main idea is to decrease the frequency and intensity of the attack. So for that, calcium channel blocker, beta blocker, and anti-epileptic drugs and antidepressant plays a very important role. So these are main points, the main outcome. So we can see the outcome if we study 6-month follow-up for intensity and frequency of the attack, so that we can titrate the dose and we can switch over the therapy. So adjuvant therapy or nutraceutical, these are also very important. Riboflavin, magnesium, so vitamin D plays a very important role. And recent study that we have already discussed, vestibular adaptation exercise and routine yoga, pranayam, that alternative medicine also plays a very important role in migrainous vertigo. And non-pharmacological therapy like neuromodulation is the recent advances. So it will the neural pathway, it will modify with the help of electromagnetic device. We can use externally or we can implant also. So these are few recent advance of neuromodulation, so yet to come. So thank you very much for patience hearing.
Thank you, Aniruddha, for your erudite and optimal presentation. I would request Dr. Haradhan Bora to please hand over the certificate of presentation to Dr. Aniruddha Majumdar. Ideally not, maybe at the end of the presentation, because we would be going with some, we have 6 more presentators. This is out of the competition. We would be having competitive session now, and this is basically a part of year-long presentation we have in all our clinical meeting. And at this outset, I would like to thank Dr. Jane Gurtu for donating the prize for best and the second best speaker in this presentation. I would request Dr. Shubhajit Banerjee, our immediate past president, and Dr. Bidhan Rai to please accompany Dr. Haradhan Bora for the judgment. I hope Dr. Saba Irfan, Dr. Srijana Shaha, Dr. Tushar Haldar, Dr. Yamuna Devi, Dr. Dipanjan Chakraborty, and Dr. Dipankar Das is present over here. The time of presentation would be 8 minutes, and you would be having another 2 minutes for answering the questions asked only by the judges. You would be adjudged on the basis of evaluation of the content and the theme of the presentation, evaluation of the quality of the presentation process and method itself, evaluation of the personality of the participant, like his or her confidence, clarity of thought, attitude, etc. To clarify more, the topic of adjudgment would be evidence level of the content, clarity of the research logic, audiovisual material of the content, set induction, that is the capacity to introduce the attention of the audience to the presentation, PowerPoint presentation content, presentation style, punctuality and the time management, capacity to arrive at a conclusion, attitude of the participant, and ability to face the interjections. Dr. Debabrata Das and Dr. Ajay Khawash would be keeping the time.
First, Dr. Saba Irfan will speak about Beruciform xanthoma, an unusual clinical entity.
Judges, may I start? Yeah. Okay. A very warm good afternoon to everyone present here. This is Sabah Irfan, second year PGT, presenting to you a case report titled Beruciform xanthoma, an unusual clinical entity. Well, we all are familiar with this actress, and apart from her acting, she is well known for her lips. The second slide is that, the second picture is that of a verses by the great poet Kalidas who praises the lips. Now, for us as individuals and for everyone else, lip is supposed to be a very important part of the face. And any cosmetic deformity affecting the lips is actually causes social dilemma for the patient. One such case I present to you is this of a 56-year-old male patient. Now, in a country like India, where tobacco chewing is so common, when such a picture comes to you, what do we think? First thing, is it a carcinoma? Looks like. What do? We take a biopsy, we do the imaging, we remove the lesion, we remove the part of the mandible, we go for flap reconstruction. It doesn't end there, then we have to go for the post-op radiotherapy, so on and so forth. Well, keeping those aside, there can be a simpler way to this. This patient, 56-year-old male patient, presented to our ENT OPD with a varicose growth on the labial surface of the lower alveolus. Now, the growth was initially the size of a pea, and over the course of 2 years, it has increased in size to attain these dimensions, that is about 4 by 2 centimeter in the largest dimension. The growth also encroached onto the lingual surface of the mandible on either sides, extending up to the 2 premolars, and involving the mesial surface of the lower lip. The patient, however, did not complain of any pain or bleeding associated with it. On clinical examination, there was no evidence of cervical lymphadenopathy as well. Noteworthy is that no other site in the body had such a growth. What was it? Well, when the first imaging modality we underwent was the CT scan, what we have to look for any bony erosion if present, what we found was the scalloping of the cortex seen on the symphyseal region of the mandible, which is evident in the picture. On histopathological examination, we found the report was suggestive of something called verruciform xanthoma. What is that? Well, to aid in the diagnosis, there were some immunohistochemistry tools we undertook for it. The first marker I would like to suggest is that of cytokeratin. What is cytokeratin? Well, cytokeratin basically is an intermediate filament which helps in forming the scaffolding of the epithelial cells. And it helps to differentiate the cells whether they are taking origin from mesenchyme or from the epithelium. The next marker you find is CD68. CD68, basically going back to microbiology, it is supposed to be a cell surface marker for the cells belonging to the lineage monocyte and macrophages. Next is the marker is P40. P40 is an isoform of the well-known this to us, that is P63. Initially, it was used to differentiate the lung CA, that is the squamous cell CA, from the adenocarcinoma. The next marker is Ki67. Ki67 basically is used to denote the rate of turnover. The more the cell proliferation occurs, the more is the value of Ki67. After performing these investigations, what we did was a definitive surgery. Well, what we did was an en bloc resection of the specimen, which was like the wide local excision along with performing the oblique marginal mandibulectomy with a special burr which is seen in the picture, that is a wheel-shaped cutting burr. And you can, how did we close it? Well, the reconstruction was done by mobilizing the mucosa from the floor of the mouth and the mesial surface of the lower lip, and it was closed in the midline. You can see the picture of the post-op specimen there. Coming to the histopathological examination, if you see my first slide, what you see is the dermal papilla, which are actually projecting deep down in the form of rete ridges. That signifies epithelial proliferation is happening at a faster rate. Apart from that, what you can see is the mixed inflammatory infiltrate. There's a lot of inflammation with plenty of neutrophils in the background. If you look at the high power magnification, my arrow actually points to a cell there. Basically, it is supposed to be a clear cell, right, with a nucleus in the center. What is it? It is supposed to be a macrophages, which is found in plenty of this lesion. I'm going to discuss what is the pathology in very soon. If you look at the post-operative result, well, post-operative day 5, we can see the lesion in the healing stage. Of course, the Riles tube was put because the patient was not taking anything per orally. And day 21, after 3 weeks of operation, when the patient returned to the OPD, you can see the lesion has healed wonderfully. With only the dentition there, which is gone. There is no other cosmetic deformity there. So anyways, I can go for a dental implant in future for that. Coming on to the thing that when such a lesion comes to us, what else can we think about? Well, in our country, as I said, initially verruciform carcinoma, the very well-known, well-differentiated squamous cell carcinoma we all are aware of, considering the local factors which prevail. Apart from that, we can think of something called verruca vulgaris, oral papilloma, which is like caused by HPV virus, and the granular cell tumor. The diagnosis can vary. There are many other such conditions like that. Coming to my topic, what is verruciform xanthoma and why am I focusing on it today? Well, verruciform xanthoma is a rare condition where it was first described by Schaefer in the year 1971. Coming to the term, what is verruciform and what is xanthoma? Verruciform actually refers to the verrucous nature of the growth, the warty cauliflower-like appearance of the growth. What is xanthoma? Xanthoma is a term used to refer to the xanthin, that is the macrophages which are filled with fat. Those are referred to as the xanthoma or the foam cells, hence comes the name. Okay, if you ask me who can suffer from it, well, you and I can suffer, yes, we can. But most predominantly it affects the people who are hepatitis C carriers, who are dyslipidemic individuals, or in immunocompromised individuals as well. In some cases, it is found in association with some other syndromes, like child syndrome, then pemphigus vulgaris, discoid lupus erythematosus, so on and so forth. After telling you all this, how does it occur? Well, there was one hypothesis which was proposed by Zagari et al. What he says is that due to an initial trauma or an insult, there's a local trauma, due to which there is epithelial breakdown. Now, this epithelial breakdown leads to some, obviously, with any insult to the body, there's plenty of neutrophils are going to come initially in the picture. After that, what happens is the epithelial breakdown is going to release fat droplets. Now, these fat things are actually scavenged by the macrophages. And those macrophages in turn appear as the xanthoma cells, which you saw in the picture. This is the pathogenesis. Now coming to it, how do we diagnose it? Well, I initially said there are two main factors how we diagnose. The first one is the histopathology, where I showed that you can see the characteristic xanthoma cells, that is the foamy histiocytes with the elongated dermal papilla, and of course with the background of this. Next is another very important aid to diagnosis is the immunohistochemistry. It plays a very pivotal role in diagnosing. Next, how do we treat the condition? Well, treatment is not bothering about radiotherapy or going so extravagant in diagnosing a disease or treating a disease. It is simple. Wide local excision of the disease. Until now in literature, no recurrence has been found whatsoever. We hope the same for our case. Anyways, these are my references, and I acknowledge my HOD sir, and of course the operating surgeon, Department of Pathology, and the patient, after all God, for giving us this. And this is my operating surgeon. Anyways, thank you so much for your patient listening. Have a good day. We actually don't have to do, like the patient when came for the follow-up, he just complained of some neuralgic pain, for which we put the patient on pregabalin and methylcobalamin. Other than that, we don't need any medical management for the case. No, those don't help. Yeah, extraoral, sir, it can occur in the oral cavity and it can also occur in the anogenital mucosa. Yeah. There are two sites which have been reported in literature, but in this case, it was just the oral cavity.
Thank you. Is it a benign condition?
It's a benign condition, sir.
Okay. Nice presentation. You have told that anogenital region is another region for this disease actually. What are the more common sites?
So most commonly it affects the oral cavity only, the palatal region and the buccal mucosa. Other than that is the anogenital. Only these two sites have been reported in literature till now.
Do you find any difference between xanthomatous warty lesions around the knee and this xanthomatous warty lesion in the oral cavity?
Around the knee?
Yes, that are the more common sites.
So
have you
mean
gone
the
through any
difference?
literature regarding this?
So the articles which I read, they were mainly pointed to these, and yeah, there was like few cases which said that there were multiple sites were involved.
Yes,
But
because these are the outcome of minor injuries.
Yes.
And the defect in our repairing process.
Repairing process.
This can happen in many parts of our body actually. Okay, thank you.
Thank you, sir.
In tune with what ma'am was telling, at the end of the presentation by 6 speakers, to increase audience interaction, if you can remember your question, we can have that at the end of the presentations. During the competition, the questions would be asked only by the judges.
Good afternoon, everyone present here. I am Dr. Srijana Shaha, second year junior resident. Today, my topic of discussion is role of narrowband imaging as a diagnostic modality in early head and neck cancers. Upper digestive tract and head neck malignancies are well known for its late presentation due to various reasons, like complex anatomy of the head neck and pathological peculiarities and multiple site involvement either synchronously or metachronously. So late presentation, the prognosis is often worsened. Now, head neck carcinomas, if detected at the stage of squamous dysplasia or carcinoma in situ, it gives the best prognosis. But diagnosis at early stage is not always very easy because of the conventional standard white light imaging cannot detect it if the lesions are less than equal to 1 centimeters. And Lugol's chromoendoscopy, which is used in gastric carcinoma, is not suitable due to severe mucosal irritation. Here comes the role of NBI, narrowband imaging, which is an endoscopic optical imaging technique to enhance the mucosal surface and the vasculature of the mucosa and submucosa. It first came into use in 2005 and it was used to detect the gastrointestinal lesions. Its principle mainly based on the depth of light penetration. The filters uses two narrow band lights, blue and green, and it penetrates only up to the mucosa and submucosa. The two bands are mainly 400 to 430 nanometers centered at 415, that is the blue band, which has lesser penetration, lesser scattering, and also it corresponds with the peak absorption spectrum of the hemoglobin and thus enhancing the intraepithelial papillary capillary loops. Now another band is 5 to 555 nanometer wavelength, that is green, which penetrates much deeper and highlights the submucosal vessels. This is the picture showing what I have told earlier. Now this system involves a standard white light imaging system, but only difference is the NBI filters. The filter is placed on the tip of the endoscope. The reflections from the mucosal surface generally comes and it captured by the charged couple device. An image processor forms an image and it is displayed in the monitor. Now this is the healthy mucosa seen in the white light as well as in the B picture. There is NBI image which shows that mucosal vessels are in brown and submucosal vessels are in cyan. These are the early neoplastic changes in general, which are the epithelial changes like thickening and vascular changes like expansion, change of IPCL loops as brown dots and irregularly placed. Now, in glottic carcinoma, there is a study by Ahmedzada and Seros, which included 52 patients who underwent white light and also NBI, followed by biopsy. 40 of these lesions proved to be squamous cell carcinoma. Now, the NI classification was used to classify the IPCL loops. These are the type 4 to 5C of the IPCL changes in the NI classification. Now, the first 3, 1, 2 and 3 are mainly the benign lesions and 4 to 5C are mainly the pre-malignant and malignant lesions suspected. Now, 5A are the IPCLs are mainly solid speckle pattern and type 5B is irregular tortuous and 5C, which is the most malignant pattern, is a very irregular tortuous and brownish speckles. In nasopharyngeal carcinoma, there is study by Wen and Zhu. 211 patients were involved with high risk for MPC. 62 cancerous lesions were suspected by NBI and it was found to be cancerous and sensitivity was 93.9%. Now, Takano et al. Classification for this IPCL loop changes were used, where the brownish, well demarcated areas with type 3 and 4 patterns were suspected to be malignant. These are the this is the white light endoscopy of submucosal growth in the nasopharynx fossa of Rosenmuller. This is the NBI image showing the type 4, that is earthworm like features of the IPCL, which suggestive of malignancy. For oral cancer, there is a paper by Dr. Deepa Nair, including 50 total patients, of which 25 patients were found to have malignancy, which was previously diagnosed with NBI or suspected to be malignant. Now, here also Takano et al. Classifications were used. Here also type 3 and type 4 are the most malignant IPSCL changes. And in the type 4, these are most changes occurs and earthworm-like features seen. A paper by Zabrowski and Lux. It included 66 patients previously treated with chemoradiotherapy. NBI suspected 17 of these patients having secondary tumor or relapse, and HP confirmed recurrent tumor in all of these 17 patients. This study by Zoanna and Klimza, 127 patients who underwent transoral laser microsurgery for laryngeal CA. These patients were divided into 3 groups, and group A consisted of the patients which has suspicious vascular pattern on NBI and positive margins, and 10 of them further was diagnosed to have squamous cell carcinoma on second look surgery. These are the few studies on NBI. I want to highlight 2 of them, which have the screening of oral carcinoma in esophageal cancers by Muto et al. And Watanabe et al. They both have shown higher sensitivity of NBI for these cases. Now, this meta-analysis by Zhou and Zhang, 25 studies were included, and the forest plot showed that pool sensitivity was 88% and specificity was 95% for NBI in diagnosis of head neck cancers. To conclude, the applications of NBI in head neck cancer diagnosis is to identify early lesions, to take biopsies from the suspicious lesion improves the yield, identify surgical margin better on intraoperative, and to decide whether the need for second look surgery is there, follow up in case of recurrent CAs, and screening of oral cancer, head neck cancer in high risk patients. There are few limitations like visual obstruction by the secretions, overall darker image which may lead to contact bleeding as a scope has to be placed very close. It is a bit expensive and not readily available. To conclude, this is a very novel screening system we can use to detect the early head neck cancers. Thank you. Now we can say, then the God said, let there be light, and we see that light is green and blue. Thank you.
Thank you, Dr. Shah. It was also a nice presentation, a new one, of course. In Calcutta, can you tell me it is widely available in all the medical
So in our institution, we do have this system. Yes, sir.
Are you trained in this? I mean, seeing the
Sir,
pictures,
is it not really? In general principle, we are not trained, but we can be trained in further. That is why I presented this topic. Is if it gets readily available, we can diagnose these cancers early, easy. But it's very easy to do it because it's only flip of the switch. We can do it. We just have to train our eyes.
you have a picture of endoscope fitted with this nerve and imaging. You have a picture. Just
Sir.
endoscope with this.
Sir, yes, sir.
Sorry for this.
Sir, here you can see the tip of the endoscope, and there is a flip of this is the switch and tip of the.
Do hemoglobin play a role in this?
Yes, sir. Yes, the peak. Actually, the blue light that is
Just
441. Yes, sir.
vascular pattern.
Yes, sir. Because the 415 nanometer wavelength matches the peak absorption spectrum of the hemoglobin. That is why it is enhancing more than the white light imaging.
And
The blue
then
light.
you can also can you diagnose a new vascularization?
Yes, sir. Obviously. So it is actually used to diagnose the new angiogenesis in the tumor vessels, tumor itself.
Okay. Is it all right now? The mic is okay. Thank you.
So what are the other sites where it will be
So mainly we can use it, actually it is being mostly used in the gastrointestinal lesions for the diagnosis of gastrointestinal carcinoma. Tracheobronchiolitis, sir, can be, yes sir, esophagus, mainly esophagus, and yes sir, mostly the gastrointestinal system. Yes sir. Thank you, sir. Sir, not regularly I would say, but it is available there. We should start. Sir, in mucosa, yes sir. Sir, in mucosa, it's seen mainly in brownish color in mucosal blood vessels, and the regular patterns differ. Vascular density differs site to site, and the submucosal vessels are mostly seen as a bluish or cyan colored vessels. Dark. Yes, sir. So it is costly, but I don't know the exact cost of the. Sir, up to the submucosa level. Sir, actually, not the mucosal peculiarities we can see. It is the only the vessel we can identify better here, and the surface of the mucosa. Surface, yes, sir. Yes, sir. Surface we can look at. Yes, sir. Yes, sir. Yes, sir. Sir, I'm not that sure, but I know that the blood vessels are seen much easier, and it will probably depend upon the experience of the. Yes, sir. Yes, sir. Auto fluorescence and everything. Thank you, sir. Thank you, sir.
Yeah.
Now you can start here.
Good afternoon, respected sir and madam. My topic is on ethmoidal mucopyosil. So, what is a mucopyosil? It is a epithelium-lined mucus and pus-filled sac involving any of the paranasal sinuses, leading to the expansion of that sinus and remodeling of the sinus wall. It forms secondary to the obstruction of the sinus involved and due to certain infective and inflammatory process within the sinus. It is usually lined by pseudostratified or low columnar epithelium. Based on a study done by Bockmull on 290 cases of mucopyosil, we can see the most commonly involved sinus is frontal sinus, which accounts for almost 43%, followed by ethmoidal, then maxillary, and the least being the sphenoidal, which is being 8%. Among the etiology of the mucopyosil, the most common is the prior sinus surgery, which accounts for almost 66%. If the sinus involved in the surgery is frontal or sphenoidal, there is much more chance of recurrence rather than maxillary or ethmoidal. Followed by spontaneous, it may be due to prior trauma, CRS without any kind of surgery, or in rare cases it might be from certain kind of tumors. So the patient who came to our OPD presented with the left periorbital swelling and bulging of the eyeball, that is proptosis, for the last 6 months, and she also gave an associated history of trauma over her left eye 2 years back. So we prepared the patient, and among the preoperative investigations, we did the routine investigations and the investigation of choice in this case, that is the contrast enhanced CT scan of the nose and paranasal sinuses. Then we did the preoperative diagnostic nasal endoscopy and preoperative visual acuity test for the documentation of vision, which came to be 6/6 in her both eyes in this case. This is the CECT of the nose and PNS, showing the mucopyosil in the left nasal cavity coming from the ethmoidal sinus, and the orbital content has been pushed inferolaterally. Then we went for the surgery for the patient, where the aims of the surgery was to widely marsupialize the sinus cavity involved for establishment of the drainage into the nasal cavity and to relieve any compressed vital structure. So we went for endoscopic marsupialization of the mucopyosil, opening the left frontal recess and ethmoidal sinus and widening the maxillary ostium. So here is a small video of the surgical procedure. So after proper nasal decongestion, we took a blunt instrument, in this case Beckesley forceps, and we made a punch in the mucopyosil wall. Here we can see the frank pus coming out of the mucopyosil, and with the help of a wide bore suction, we did the suctioning of the pus coming out from it. Then we took the same Beckesley forceps to punch out to wide the area of the punch site previously in order to have a greater access. Then we remove the part of the wall of the mucopyosil here, and we can see a lot more pus coming out. Then using an upturned Beckesley, we again punched out the wall where it was not accessible by using a straight Beckesley. And after gaining a proper access into the mucopyosil, we can see a lot more pus, which we did suction using the same widebore suction. Here we can appreciate the anterior ethmoidal artery at the center of the screen, and after a gentle suction, we used a Carrison punch to punch out the superior, medial, and lateral aspect of the wall of the mucopyocyl here, just beside the axilla of the middle turbinate. Then again, by taking the Beckesley forceps, we remove the punched portion of the wall from the mucopyocyl, and the pus which is coming out has been washed out using copious irrigation. Here we can see we are using the copious irrigation for removing the pus from inside the mucopyocyl. Then here we can appreciate that by pushing the medial wall of the orbit, we can see that the lamina papyracea can be delineated. Now we are using the micro debrider for removing the mucus from superiorly, inferiorly, laterally and medially in order to have much more access into the mucopyocyl. And here we can appreciate the medial maxillary antrostomy site. And when we took a 70-degree endoscope and the upward cannula is pushed superolaterally, we can appreciate the frontal recess. By taking the backbiting forceps, we are clearing the anterior wall of the medial maxillary antrostomy site, and using the upturned cannula, we are removing the polypoidal tissue within the maxillary ostium. Now we can see clearly the maxillary ostium which is free from the polypoidal tissue. And taking a giraffe forceps, we are removing the bone from the frontal recess. Again, we can appreciate the lamina papyracea on pushing the medial wall of the orbit. And finally, by using the upturned cannula, we are removing the mucus and pus remaining inside the nasal cavity. The possible complications that can occur here include the recurrence, bleeding, CSF rhinorrhea, orbital injury and stenosis of the neighboring ostia. When the patient came for a post-op visit, we performed a diagnostic nasal endoscopy, and here we can appreciate the anterior ethmoidal artery in the superior aspect, the maxillary ostium which is patent, and polypoidal tissue which will subside in due course of time. Moving forward, again we can see the anterior ethmoidal artery, marsupialized cavity, and the polypoidal tissue in the lining of the cavity and the lamina papyracea. On taking a 70-degree scope, we can see the opening of the frontal recess. And this is the image of the patient who came for the post-op visit after 2 weeks. The limitations of this study can be noted as MRI was not done, pre-op perimetry was not done, and the time for the post-op follow-up has been too short for a conclusive result. Thank you.
Thank you, Dr. Haldar. It was also a good presentation.
Thank you, sir.
You did it yourself.
Yes, sir.
You talked a lot about frontal recess.
Yes, sir.
What are the areas where frontal recess drains actually?
Frontal, sir, actually the frontal recess is anteriorly will be the uncinate process, and
I'm not talking about the boundaries, I'm talking about the drainage area.
okay.
Frontal recess has another name.
Yes, sir.
Any other anatomical name of
Oh.
frontal recess?
Recess. Sorry, sir.
So, but actually, I'm a little bit confused actually. What is the objective of presenting this case here?
Sir, this is a case study actually.
A single case study?
Yes, sir. Single case study.
Presentation?
Yeah, single case
What is
presentation.
the objective behind this?
Objective is the way we have treated the patient, that is the endoscopically we have gone for it, not by any external approach, and how we have seen the patient from the beginning and like that.
Okay. Then why you are calling it as a frontoethmoidal mucopyocyl?
Actually, sir, I have informed that previously that it will be ethmoidal mucopyocyl. I have informed that already previously.
And after puncturing the wall,
Yes, sir.
you are visualizing the anterior ethmoidal artery directly.
No, sir. That after the pus coming out and
Yes.
when we have cleared it out, then after when
What
we
you have cleared? Do you have cleared any posterior bony wall of the mucopyocyl?
yes, sir. Posterior bony wall.
You have cleared it.
Yes, sir. I have shown that using the Beckesley we have turned down the bony wall.
posterior wall of the mucopyocele.
Not the posterior wall of the mucopyocele, but when we have
And
gone to
how
the ethmoidal,
anterior ethmoidal artery comes under vision within the frontal cell.
it will be seen when we enter into the ethmoidal sinus.
Yeah. So you did enter into the ethmoidal sinus.
Yes, sir.
That was not shown in your video.
Oh, sorry, sir.
Okay. Thank you.
Thank you, sir.
Okay, thank you. Our next speaker is Yamuna Devi, and her topic is Yamuna Ranganathan. Huh? And what is your presentation actually? Topic of presentation?
So it's a,
Here it is written as tennis syndrome. I mean,
a recurrent papillary carcinoma of thyroid with laryngeal invasion. It is actually a tennis syndrome.
please start.
Good afternoon. Myself Dr. Yamuna. I'll be presenting a case of recurrent papillary carcinoma of thyroid with laryngeal invasion. And my patient is a 60 years old female. In 2004, she was diagnosed as a case of papillary carcinoma of thyroid, for which she underwent total thyroidectomy and bilateral lymph node dissection with adjuvant radioactive iodine. She was on regular follow-up with serum thyroglobulin, but in the year 2014, her thyroglobulin was on the higher side, that is 38.5 nanogram per milliliter. She underwent a iodine scan to look for the recurrent and the metastatic disease, but it turned out to be negative. She was administered empirical RAI of 100 millicurie. The similar finding in the year 2015, for which she also been administered empirical RAI of 120 millicurie. But in the year 2016 and 17, the thyroglobulin was on the higher side of 181 nanogram per milliliter. In the USG, there was a well-defined lesion in the right thyroid bed, and in the PET-CT, there was a avid lesion in the right lobe of the thyroid. And FNSE was done. It was suggestive of papillary carcinoma of thyroid. And then the recurrent disease in the thyroid bed was excised, and the post-op HPR was also suggestive of papillary carcinoma of thyroid. She was on regular follow-up in the succeeding years, but in that time, thyroglobulin was on the higher side. In 2020, in view of increased thyroglobulin, she underwent PET-CT, which showed a FDG avid lesion in the right subglottis. In the MRI neck, it was abutting the right undersurface of true vocal cord. But the biopsy, it was suggestive of no malignant changes. And she was also lost to follow-up because of COVID. But in the year 2022, she presented to our OPD with a 3 months history of difficulty breathing. On evaluation, neck was NAD, fiber optic laryngoscopy was done, which showed a suspicious subglottic lesion which was present anteriorly. And the thyroid function test was all within the normal limits, and the thyroglobulin was again on the higher side. She underwent CECD base of the skull to dome of the diaphragm. Here there is a lesion in the subglottis which is crossing the midline to the left with the erosion of the thyroid as well as the cricoid cartilage. And there are subcentimetric cervical lymph nodes bilaterally, but the left level 6 was significant with the size of 1.3 centimeter, and there were also multiple pulmonary nodules were seen. In the PET-CT, there was a FDG avid lesion in the right lobe of thyroid, and the subcutaneous solid nodules in the lungs were also seen. But in the right subglottic region, the SUV was 74. In the year 2020, in that PET, it was SU of 24 only. And with this, we proceeded with the elective tracheostomy, and through the tracheostomy site, the biopsy of the subglottic growth was taken. This post-op HPR was suggestive of papillary carcinoma of the thyroid. The case was diagnosed as a recurrent papillary carcinoma of thyroid with laryngeal invasion and thyroglobulin elevated negative iodine scan syndrome. According to AJCC, she comes under the staging was RYC, T4A because of laryngeal invasion, N1A because of significant node, M1 because of pulmonary nodule, and stage 4B as she is of more than 55 years. Case was discussed in multidisciplinary team, and we made a decision of proceeding with the total laryngectomy, lymph node dissection of level 6, and adjuvant chemotherapy. And we thought radiotherapy we will keep it as for salvage in case if she develops future recurrence. And patient was counseled about the surgery, and under strict aseptic precautions, we proceeded with the surgery, and after giving the incision, subplatysmal flap was raised both superiorly and then inferiorly. Strap muscles were cut to visualize the larynx. Paracarotid tunnel dissection was done on either side, and this is the lymph node dissection of the right side, and it was also removed on the left side. And this is the muscle attachments on the lateral border of the thyroid cartilage was cut. Similarly, the muscle attachments on the hyoid bone was also cut. The similar procedure is repeated on the other side also. And the pharyngeal mucosa in the pyriform fossa was preserved by elevating the mucoperichondrium on the inner surface of the thyroid cartilage. And the trachea is cut between the third and the fourth tracheal rings. After the cut is made, the airway was transferred and the dissection above the hyoid bone was done for pharyngotomy. And this one is the pharyngotomy through the vallicula, and the larynx was visualized from the above. And the structures which were seen are, as a surgeon is showing, that is epiglottis, pharyngoepiglottic fold on the right side, PE fold on the left side, that is arytenoid, epiglottic fold, the anterior part. And cut along the PE fold, AE fold was made, and post-cricoid area was also done to separate the larynx and the pharynx. Dissection between the trachea and the cervical esophagus was done. The specimen was delivered out and sent for HPE, and this is the maturation sutures were fashioned. And we have measured the remnant of pharyngeal mucosa. It was actually more than 3 centimeter for the creation of neopharynx. And the clavicular head of sternocleidomastoid was removed on either side to make the stoma shallow. And this is the TEP incision, pharyngeal protector, and below is the cannula, and the guide wire is inserted through the cannula, and the pharyngeal protector is removed. Following that, sheath is inserted, that is the TEP, and the guide wire is snugly fit at the other end of the TEP prosthesis site. Following that, the TEP with the prosthesis and the guide wire is removed through the stoma site, and it is placed in the position. This is the cricopharyngeal myotomy to prevent the future stenosis. And the vertical extramucosal sutures were made for the creation of the neopharynx, and this is the well-healed stoma picture which was taken on the POD10. And the post-op HPR was suggestive of poorly differentiated carcinoma, that is insular variant of papillary carcinoma of the thyroid. She was started on the tablet lenvatinib, and at present patient is doing well. And coming to the discussion part, papillary thyroid carcinoma is the most common thyroid cancer, accounting for more than 90% of all thyroid cancers. When it comes to well-differentiated carcinoma invading the aerodigestive tract is actually a rare finding, with an incidence of only 5 to 13% has been reported in the literature. The risk factors for such an invasion is, as in my case, she had a poorly differentiated aggressive histology, and she is also an old age patient, recurrent disease, because since 2004 she has presenting till now. But as the papillary thyroid carcinoma is a slow growing malignancy, and it is also not that much aggressive as squamous cell carcinoma, but it has to be addressed in the first go, and there is a chances of de-differentiation, as in my case. Initially it started with papillary and later it ended up with poorly differentiation because of the de-differentiation. In case of distant metastasis, surgery gives the palliation and it prevents the development of aerodigestive symptoms. And these are my references.
When this operation was done?
Sir, 2 months back, sir. One and a half hardly.
Are you following?
Yes, sir. She is on regular follow-up with us. At present, she was started on chemotherapy, and 15 days or 20 days she was on drugs, sir, chemotherapy. She'll be following after 10 days. Sir?
Total period from the sufferings is 10 years.
Sir, 2004, 2022 tak she had this recurrent ka course, sir.
Very good presentation, Dr. Yamuna.
Yes, sir.
Nothing more to be asked, but can you just, what is the abbreviation of tennis?
Thyroglobulin elevated negative iodine scan syndrome, sir.
Did you show it in your?
Sir,
in a
that was
slide?
the finally my discussion. In between that had
Was there a
happened.
slide of tennis? Just presenting this tennis syndrome slide, the whole meaning of tennis.
Sir, in the year 2015, the iodine scan, everything, empirical RA was given. That time she has been diagnosed. So that is why I have elaborated 2014 ka presentation. 2015, it is negative. So that is what I meant to say about the tennis at that
Okay,
part.
thank you.
So, you were discussing about the surgery or about the tennis syndrome. Which one was your highlighting area?
So the treatment course, entire course of this,
Treatment course of this particular case,
yes, sir, the thyroid papillary started with the poorly differentiated, how we have managed the case.
which falls under the tennis syndrome.
Yes, sir.
You were not discussing about the tennis syndrome.
So, but the papillary to poorly differentiated, I want to explain. That is what
You
I
want
thought
to
of
explain
discussion.
this.
Yes,
Do you
sir.
have any data regarding the prevalence of tennis syndrome in post-surgical cases of well-differentiated thyroid carcinoma?
So,
Do you have any data? How
So I have
many?
not.
You don't know. And when do we measure the thyroglobulin level? When the patient is on full-blown supplementation of thyroxine, or we try to alter the dose a little bit to estimate the thyroglobulin level?
So it is both stimulated and unstimulated thyroglobulin is
Stimulated and
unstimulated
unstimulated.
thyroglobulin.
And you showed the result as around 30
So 38.5, sir, initially.
that was the pre-operative level,
So that is 2000.
pre-surgical level actually.
So that was post surgery of total thyroidectomy.
Yeah.
First, after 10 years of follow up, that was the result, sir.
At that time, patient was receiving thyroxine full supplement.
Yes, sir. She was also on receiving the supplement also, and
There was no alteration in the dose of the thyroxine.
sir, she presented to us in 2022 only, sir.
Yeah.
But these were all the documented data which we had that since 2004. What has been documented, that
So
data
you
only we had.
didn't think about TSH suppression or stimulation?
So she was on TSH suppression of 200, sir.
200.
Dose.
That's it. Okay, thank you.
Dr. Deepanjan Chakraborty, topic is spontaneous cerebrospinal fluid rhinorrhea, the emerging cause and adjunctive measures.
Good afternoon to respected judges and the delegates. I am Dr. Deepanjan Chakraborty here to present on spontaneous cerebrospinal fluid rhinorrhea, the emerging cause and the adjunctive measures. So to begin with, we know that cerebrospinal fluid circulates within the ventricular systems of the brain and the spinal cord, providing important functions of nourishment, waste removal and protection. Rhinorrhea occurs when there is a fistulous communication between the subarachnoid space with the sinonasal cavity following a defect in the skull base. So traditionally in literature, in terms of etiology, this condition has been classified into spontaneous, traumatic and iatrogenic forms. While plenty of work was being done in the traumatic and iatrogenic categories, the spontaneous form was ignored until the work of Omaya, who classified this situation into high pressure and normal pressure situations. And concomitantly in literature, another condition showed an exponential increase in prevalence as well as in incidence after 2017, that is benign intracranial hypertension. The major risk factors for which has been enlisted as female gender, obesity or weight gain, endocrine disturbances, steroid use or withdrawal, and hypervitaminosis A. Further studies refuted the association of benign intracranial hypertension with this condition, and also more studies attributed the epidemiological risk factors to both these conditions in terms of age, gender, and obesity. This study summarizes this as in terms of incidence and prevalence, that is 45% of our non-traumatic cases are high pressure leaks and 55% are normal pressure leaks, where the rhinorrhea occurs due to physiological alteration in CSF pressure leading to point erosions in the skull base. With this background, we come to the aims and objectives of our study, where we intended to describe the epidemiology of spontaneous cerebrospinal fluid rhinorrhea, to identify and categorize these leaks into normal or high pressure situations, to identify the site of skull base defect and thereby optimize management, not just in terms of surgery, but also in terms of post-surgical adjunctive measures. This was an institution-based prospective study from January 2020 to February 2022, where we included 23 consecutive cases of spontaneous CSF rhinorrhea based on clinical features, biochemical analysis of protein, sugar and chloride, and radiological investigations, excluding the ones lost to follow-up, the ones with congenital anomalies or coexisted intracranial tumors. Our results showed that majority of the subjects, that is 14 out of 23, belonged in the 5th decade of life with a mean age of 48.48 years plus minus 11.06 standard deviation. 17 of our 23 subjects were females and 6 were males, presenting mostly with the steady flow of fluid on head bending, while in one of our cases we saw the classical teapot sign. So, using the modified Dandy's criteria for imaging in these situations, we came across certain high pressure situations, that is, firstly the tortuosity of the optic nerves, the classical dilatation of the Michel's cave, presence of empty sella in one of our cases. We also saw meningocele in most of our cases with cribriform plate defects. Also, in one of our sphenoid sinus defects, in addition to the skull base defect, we could see adjacent thinning of the skull base. And one of our cases also presented with papilledema. So, in all the 23 spontaneous leaks cases, according to these conditions, 11 were cases of high pressure situations and 12 were with normal intracranial pressure. So among the 11 high pressure signs, among the multitude of signs that were present, most commonly we could see optic nerve tortuosity and presence of meningocele, 5 with cases of Michel's cave dilatation, a couple of cases with adjacent skull base thinning to the defect and empty sella, and 1 case of papilledema. Epidemiologically, in these 11 high pressure leak cases, 6 out of 11 cases were in the 5th decade of life, with an overwhelming majority of them being females with a body mass index of more than 30 kg per meter square. And risk factor wise, 2 of them were on steroid therapy and 2 on oral contraceptives, both of which have been separately implicated as risk factors for benign intracranial hypertension. To identify the site of skull base defect, we chose an HRCT scan of paranasal sinuses in 1 mm sections, which shows the defect in most of the cases, a CT cysternography which is very useful in active leaks, and of course the MR cysternography with screening of brain. And of course we need to associate dynamic studies with static pictures, because this is one doubtful situation where the leak was actually in the clivus of the sphenoid sinus, pooling in the lateral recess. So result wise, out of the 23 total cases, 22 were defects in the cribriform plate and 1 in the sphenoid sinus. And if we cut down the high pressure situations, out of 11, 10 were defects in the cribriform plate and 1 in the sphenoid sinus. Surgically, we use the graft of consisting of fat and fascia lata, which after harvesting we keep in a bowl of normal saline. And previously, we created the bath plug by applying sutures to the fat globule only, while in our study we have slightly modified this to wrap this fat globule in a piece of Surgicel, after which we applied the sutures to create a modified bath plug. So just an idea of what we usually do, this was a comparatively easier case of a medial lamellar leak with a meningocele. We removed the concha bullosa, which was actually hindering our exposure. We localized the site of defect and cauterized the meningocele and created the 5 mm surrounding mucosal denudation and palpation of the bony margins and the defect, followed by introduction of this fat Surgicel complex and then reinforcing this with the layer of fascia lata. And wrapping this fat globule in a piece of Surgicel is usually more convenient to the surgeon in terms of introduction of the graft into the defect. Surgicel also cauterizes the adjacent residual leaks and allows for better integrity of the seal, which can be checked at the end of surgery. We follow a strict postoperative adjunctive protocol depending upon the high pressure and low pressure situations. In spite of that, at 3 months post surgery, one of our case complained of headache and visual blurring, and 2 of new onset rhinorrhea, which was coming from the opposite side. These were all cases of high pressure. Now coming to the discussion part, most of our cases in terms of age, in terms of gender, in terms of body mass index, most study, and of course in terms of the skull base defect sites and the choice of imaging, also most studies show findings similar to our study, and this study also highlights the high recurrence rates in cases of high pressure situations. So a meta-analysis from all these studies that we undertook showed that in addition to the routine adjunctive postoperative measures that we usually carry out in cases of CSF rhinorrhea, special emphasis is to be given in high pressure situations in terms of weight reduction, low salt, calorie and vitamin A restricted diet, use of acetazolamide therapy, preferably for longer duration, or furosemide, to take appropriate drug history for steroids or OCP use, and of course the last resort remains a lumbar drain, or even in worse situations some kind of CSF diversion procedure. So to conclude, for spontaneous leaks, preoperatively it is very important to categorize them into high pressure or normal pressure situations. Only then can we undertake surgery, and followed by correction of risk factors and post-surgery adjunctive measures, and then regular follow-up which can prevent recurrence. Although this is not a tailor-made management, this requires the management for every patient to be individualized, and that is only possible with the help of a multidisciplinary team approach. Only then can we achieve the best post-operative results. These are my references. Thank you. So total number of cases were 23. Time roughly a bit more than 2 years. Yes, sir. In 3 of our cases, all those 3 were high pressure situations. So we had 11 high pressure situations in our study, and among them 3 had recurrences, and roughly 3 months post surgery. One of them with new onset headache with visual blurring, and 2 of them with new onset CSF rhinorrhea, which was coming from the opposite side.
Very good presentation. Can you name the protein which is present in CSF?
Yes, sir. Most commonly, as per protocol, we should check for beta-2 transferrin, but at our institute, due to non-availability of resources, we only performed biochemical analysis of protein, sugar, and chloride, along with clinical features and radiological investigations.
So your sample size is of
23.
23 cases.
23.
Out of those 23 cases, you had recurrence in 3 cases. Is it at par with the available literature?
Sir, overall, the success rate for endoscopic repair in these cases, in one of the articles that I cited, was overall success rate was roughly 84%.
You have not subcategorized it into normal pressure and high pressure when you are talking about the 23 samples. You have included all the cases having normal intracranial pressure and high intracranial pressures. And out of those, you had 3 recurrences. I want to know, is this at par with the literature review? Or what extra, if it is not so, what extra precautions you advocate to improve the outcome?
Sir, in terms of ideally speaking, also in availability with literature, we should actually be able to measure the CSF pressure, even if you are going for a lumbar drain or a CSF diversion procedure as per indication. After removal of the lumbar drain, after 48 hours, we should also try to check for a CSF pressure. This is the one thing we could not do in our study, which can be considered a limitation.
Dr. Dipankar Das, and his topic is fungal granuloma of maxillary sinus, a diagnostic dilemma.
Good afternoon, respected judges and other teachers. Today I am going to present one case of fungal granuloma of maxillary sinus with real diagnostic dilemma. One patient with presented to our OPD with right-sided cheek swelling for last 2 years, and this is the swelling. And with this history of insidious onset and gradually progressive, and associated with difficulty in chewing and loosening of teeth in upper right jaw, and no other aggravating or relieving factor, and associated with cough with expectoration, and not associated with pain, fever, and other these symptoms. And there was no history of loss of appetite and significant weight loss in last 6 months. And patient was undergone endoscopic biopsy under local anesthesia from right maxillary sinus after doing wide MMA on January 2021, and the result came as epithelioid granuloma. And subsequent with at the same time fungal stain was done, and it came as septal hyphae that suggests aspergillus. And then as patient was having cough and fever, old cough, chronic cough, and this patient was diagnosed at pulmonary tuberculosis. In January, the patient was started with category 1 DOTS, and is completed in the full course of DOTS treatment. For this reason, patient was not regularly treated with medical therapy. Then patient with past medical history of hepatitis B reactive. Patient was hepatitis B reactive from very early for like 5 years, and patient was taking entecavir from February 2021. And there was no history of diabetes and hypertension. Patient patient had a past surgical history of undergoing surgery for anal fissure under spinal anesthesia 4 years back. There was no history of smoking, and patient was occasional drinker, and no history of porn bathing, and family history. There was no family history of malignancy, and the patient was not allergic to any drugs or foods. And patient came from very low socioeconomic condition. Then on examination, this is the first presenting day. There was one swelling noted. Noted in the right cheek. The surface of the swelling was smooth and with diffuse margins, and it was extended from the right infraorbital rim to upper alveolar area. And I have confirmed my inspector's finding with palpation. That there was no local temperature raise, and there was no pain and tenderness, and there is no tenderness, and the surface was smooth, and the margin was diffuse, and the extension was from the lower infraorbital rim to upper alveolar region. Then the mass was fixed to the underlying tissue, and the free skin over the overlying the skin was free. And the oral cavity, there was poor orodental hygiene, and palate was normal, and one cyst or swelling was seen below the right lower lip. And on the other examination, like ear examination, nose examination, everything was within normal limit. Then we did one OPG on October 2021, and it shows that there is a odontogenic cyst with a horizontally placed canine on the right side, and these and over this the erosion of the right alveolar part. This. Then we did CT scan. CT scan shows there is soft tissue swelling on the right side and with a alveolar erosion, and the soft tissue is extending to the soft tissue of the right cheek, and there was concha bullosa, coincidental finding with bilateral concha bullosa. Then this same picture. Then we did MRI of nose and PNS, and it shows the enhancing mass of the right maxillary sinus, which is extending anteriorly into the buccal fat, and eroding the antral wall. And other sites like orbits, pterygoid plates, and pterygomaxillary fission, and infratemporal fossa and naropharynx was free from the tumor. And there was subcentric lymph node on the right side, level 1A and 2. And after this, doing proper history and investigation, we had planned for surgery, as it was involving the mandible alveolar part and with the maxillary sinus. We have gone for combined approach, that is open with endoscopic approach. In this both approach, we have removed the mass in toto, and the maxillary wall was drilled endoscopically to remove the remnants of the tumor. Then this mass was sent for HPE, histopathology examination. Histopathology examination came as this inflammatory cells infiltration of the mass, and with the multiple granuloma that shows the presence of Langerhans cells and giant cells, that confirms that it is a granuloma. Then another fungal stain, GMS stain, and periodic acid stain was done, and it shows fungal spores and septate fungal hyphae. That also confirms that it is a aspergillus. Then the patient was postoperatively treatment was started with itraconazole for 6 months with regular liver function monitoring with nasal douching. So this is the post-op follow-up. Patient was absolutely normal. There was no symptoms, and oral cavity was normal, and post-op DNA was absolutely normal with evidence of right-sided MMA, wide MMA with no recurrence or residual. So now what is the main dilemma for this diagnosis in my case? That is, patient is a immunocompromised patient with history of beta CG reactive with history of pulmonary tuberculosis. So this granuloma first may be due to tuberculosis or extrapulmonary tuberculosis, but patient received total course of treatment with category 1, full course 6-month treatment, but the mass does not resolve, but there was no reduction of symptoms. So we can easily exclude tuberculosis. Then another thing that come in our mind, that is malignancy, as there was erosion of the bony wall of the anterior inferior wall of the maxilla. So obviously one differential diagnosis of malignancy comes in our mind, but In favor of in favor of malignancy, the erosion of bony wall is there, but the history is long standing and there is no history of loss of weight, and there is no loss of sensitivity of the cheek, and these are the points. And the HPE, this HPE goes in against the malignancy. Then other thing, that is finally the fungal pathology. This fungal stain came as aspergillus, and the fungal ball was removed on during surgery. This is the surgical we have confirmed during surgical surgery, and the patient was absolutely treated fine after treatment with itraconazole postoperatively. So this clinical surgical and HP diagnosis, and this all confirms my diagnosis as a fungal granuloma with complications. These are the literature we have reviewed, that also shows that if fungal sinusitis is not treated early, then it can cause complications like bony erosions. And there is some literature shows that there is a postoperative itraconazole therapy can reduce the complications. So the main thing in my case is two things: the fungal granuloma with bony erosion and the itraconazole therapy. If we encounter the fungal sinusitis earlier, this we can avoid the complications like bone erosion and other soft tissue involvement. And itraconazole usually not prescribed in regular fungal sinusitis, but in case of complicated, or in my case, with in keeping the scenario, the this immunocompromised scenario, we have started and find good result. Good result. Thank you.
Thank you, Dr. Das. Do you still believe that immunocompromised patients suffer much more in granulomatous lesion or immunocompetent patients? Normally.
Immunocompromised patients.
For granuloma.
Yes.
What are the doses of itraconazole you have given just after surgery?
200 milligram twice daily for 6 months.
That means 400 for 6 months.
Yes.
Didn't you give any IV itraconazole like that?
No, sir. We did oral.
Orally. Okay. And what are the commonest side effects of itraconazole? Because it is a very, symptom producing drug.
Is a liver is a hepatotoxic drug.
Liver toxic, hepatotoxic drug.
Yeah.
Can you keep in mind, do you think there are other fungicides or like that, apart from itraconazole? If you can't give itraconazole, is there any other antifungal medicine? Sometimes, normal, not normal. Sometimes.
Fluconazole.
Fluconazole?
No.
So your preoperative diagnosis was?
So preoperative diagnosis was that preoperatively was biopsy was taken, and although also fungus stain was done. So preoperatively we found that there is granuloma with fungus.
So it
but there was bony erosion also. So we had to go for biopsy.
So it is simple fungal granuloma or granulomatous invasive fungal sinusitis.
So this is fungal granuloma with complications, like bone erosion.
With complications, not granulomatous
Invasive, not
fungal.
invasive.
Why not?
Sir,
what is the point against it?
So the other perisinal part.
Periantral soft tissue shadow, bone erosion was there in your CT scan?
There was a homogeneous and in invasive fungal it will be double density.
Okay.
Sorry to ask you again.
Yes.
What are the type of aspergillosis you found that? Just you cannot say aspergillosis. There is some subtypes of aspergillosis. Was there any?
Thank you. Thank you.
Thanks will be given by
The presentations are now open for audience interaction. We can give 10 minutes, no? With the permission of the judges. Or, হ্যাঁ এটার সাথে এদের কোনো প্রশ্ন নেই বা নম্বর দেওয়ার কোনো ব্যাপার নেই Do you have any question, ma'am?
Yes, ma'am.
Yeah, you presented very well.
Thank you, ma'am.
I just wanted to ask you, why did you do the marginal mandibulectomy? Because this was not a malignant case. This was a benign case. So I think removing the mandible was an overkill.
Ma'am, basically, like initially when I pointed out, when we did the CT scan, the CCT as well, I pointed out that the lingual surface of the mandible was also involved with the mass. And hence,
You
like
mentioned
to
it
get...
was scalloped. Scalloped means there was a depression on it. There was no erosion.
Ma'am, that was on the outer surface I've mentioned. The lingual surface I'm talking about, that was encroached with the mass. And hence, to remove to do the en bloc resection, we had to like remove a part of that. We did the marginal mandibulectomy.
A benign lesion generally doesn't involve the mandible, so
Okay, ma'am,
that was
that
one
is
of-
okay.
Okay. I mean, the another way of approaching the case would have been to do an excision biopsy of the whole lesion without removing the mandible, check histopathology. If required, then go ahead and resect the mandible if it comes positive on the...
Okay, ma'am. Thank you for your...
And the second question I wanted to ask for the fungal granuloma. So I wanted to ask you that the final HPR did not show any invasion of the fungus, right? In the histopathology.
HP showed the granuloma.
Granuloma,
And
right.
the stain, postoperative stain showed the septate hyphae.
Stains. Okay, so stain is done for the
Fungus.
I mean the swabs that you take from the surface. It is the stain is not for the invasion. So invasion can be only talked about on histopathology. You cannot talk about it on stains, right?
Yes.
So what I wanted to ask was, why did you administer itraconazole? Itraconazole is given for invasive fungal rhinosinusitis.
Ma'am,
There is no invasion reported here, so and no evidence of any fungus going into the tissue. So the reason for itraconazole is
as
not
ma'am,
understood.
patient was immunocompromised and there was complicated with bony erosion. That's why
Bony
I started-
erosion can happen because of hyperemic decalcification because of the granuloma.
Yes.
That can happen.
Yes.
So itraconazole administering without any evidence of invasion, again, I would not give it at least.
So what are the size of perforation? Leaks. Sorry. Leaks. Have you assessed this?
Yes, sir. Roughly 3
You have
millimeter.
not mentioned this into your study. And is there any relations with the size of the leaks with the recurrence?
Sir, that part we haven't
Or is there any
discussed in
role of
this.
conservative management in case of low pressure CSF leaks?
Sir, it was actually either high pressure or like normal pressure. So firstly, we did assess the size of the defect using the standard 3 millimeter Q rate that we have. So the average defect was roughly 3 millimeter. Even the sphenoid sinus defect was 3 millimeter. So the video that I showed, the skull base defect was roughly 3 millimeter or less. We did not address the adjacent thinning part. We left it as it is. We followed that up with conservative management.
So all the leaks are of 3 millimeter.
More or less, roughly.
Is there any relations with the leak and the recurrence?
Usually, we would associate a high intracranial tension with either larger defects or multiple defects in such cases. So that part we haven't highlighted in the study. Firstly, if we have a meningocele, the first thing we have to do is to cauterize the meningocele. If there is any active leak seen during the time of surgery, most of the times cauterization itself seals the defect, firstly. Secondly, we create the 5 millimeter denudation of mucosa adjacent to the leak. We palpate the bony margins and the dural defect, and then in the meantime, the assistant prepares the graft. So for preparation of the graft, we have used the fat globule wrapped in Surgicel, following which we have applied the plugs. So this was our first layer. We have introduced the fat wrapped in Surgicel initially. We have taken it close to the defect. We have used a blunt ball probe to gently introduce it along the margins of the defect. That was the first layer. Second layer is usually another layer of Surgicel followed by an onlay layer of temporalis fascia, fascia lata, followed by another layer of Surgicel, and then finally the tissue glue.
Specific markers available in India, but alternate to beta to transferrin, there is beta trace protein which is easily available in India, and most of the labs, disclaimer here, not associated with any medical companies, but Lal has that conduct. So beta trace protein is available and it can be easily done.
Is it specific for CSF?
Yes, it is equally sensitive and specific to beta. It is, they do 3 markers in that, which includes around 500 rupees. So if patient can afford, you can take it. We have been doing it, and I know this. We have been doing it in the army with Lal. They have some content accounts. So I am not left. Other centers may also be doing it. And beta trace protein. So there is ample evidence, and it is equally sensitive and specific. And thirdly, I just wanted to know, you have classified your CSF link into high pressure and low pressure. So did you measure the CSF pressure? If so, how? Then how did you classify them into high and low? And what is the ideal time to check the CSF pressure?
Sir, we have not used CSF pressure as a criteria, which we considered a limitation in our study. Firstly, we used the modified Dandy's criteria in terms of imaging, MRI, to look for the high pressure signs like optic nerve tortuosity, like dilatation of Michel's cave, one of our cases with empty sella, if the patient has symptoms related to vision in the preoperative period. That also.
I would request Dr. Jane Gurtu to please join with our revered judges in giving away the certificates to the participants. Dr. Saba Irfan. Well done, Saba. Dr. Srijana Shaha. Dr. Tushar Haldar. Dr. Jamuna Devi. We can have bigger round of applauses for these participants. Dr. Dipanjan Chakraborty. Dr. Dipankar Das. Well done, participants. Thank you, judges and Dr. Gurtu. Dr. Gurtu, would you like to say something? যারা ছিলেন না তাদের একটু মনে করিয়ে দিই, we have year-long clinical meeting for the Association of Otolaryngologists of India, West Bengal chapter, and Dr. Gurtu has donated the first and second prizes for the best speaker. Dr. Gurtu.
Well, I passed out in 1967, and since then I was in post-graduation in ENT. From that time to now, and even after coming to Calcutta in 1978, I find tremendous change and improvement and progress in clinical presentation and the standard of development of the AOI West Bengal branch. So my congratulations to all of you. Very good participation, very good interaction from the judges, and I feel very happy to be associated with this branch. Thank you so much.
I thank President, Secretary and the Executive Committee of Association of Otolaryngologists of India, West Bengal, for selecting Bhagirathi Neotia Women and Child Care Center for the venue of the first clinical meeting for the session 2022-23. I thank Dr. Johnson & Johnson for participation in this clinical meeting. I thank the audiovisual and the supportive staffs of Neotia for making this clinical meeting a great success. I thank the office bearers and staffs of Association of Otolaryngologists of India, West Bengal. And last but not the least, the audience for making this a grand success. Thank you very much.